Hi, I'm Dr. Amy Krambeck. I am professor of urology at Northwestern Medicine, and I am the chief of the Division of Endourology in the Department of Urology. The case that I will be discussing today is of a 68-year-old gentleman who came to Northwestern Medicine for a holmium laser enucleation of the prostate. He has a long history of benign prostatic hypertrophy, or BPH symptoms. 6 years prior to seeing me, he had undergone a holmium laser ablation of his prostate, which is where they burn the tissue. 3 years prior to seeing me, he had had another surgical procedure called a green light laser ablation of the prostate. And then his symptoms still continued despite these two treatments. He was taking finasteride and Flomax, full-dose medications, and continuing to have urgency, frequency, double voiding, getting up at night. So pretty miserable and significant symptom scores. He had heard that HoLEP, holmium laser enucleation of the prostate, is very good for repeat procedures and had sought me out for treatment. On his initial workup, he had a very poor flow. His max flow was 8 cc's per second. He had a post-void residual of 250 cc's, and his prostate measured approximately 160 cc's on a CT scan. So on the CT imaging, you can see that there's a very large median lobe and large prostate with bladder distension. Because this patient had had such a complex surgical history and persistent symptoms, I wanted to do a full workup. So I did a uroflow with ultrasound residual, which showed a very poor flow, high residual urine after urinating. I also wanted to ensure that he did not have prostate cancer. So I did a PSA, which was 3.5, and he's on finasteride with an extremely large prostate, so that was fitting. He had been in the 3.5 range for many years without any change in his PSA, so I think it's important to look at the velocity of PSA change over time, especially in men with large prostates. And I also wanted to do a cystoscopic evaluation. His symptoms could be persistent because of urethral stricture disease, bladder neck contracture, so I generally reserve the cystoscopic evaluation for either men who are very young or men who have had multiple prior surgical procedures with persistent symptoms. I did not perform a urodynamic study because studies have indicated that even if a patient has an acontractile bladder, in the presence of persistent BPH, they have a good chance of urinating after HoLEP. So I rarely will ever perform a urodynamic study unless a patient has a known neurologic condition or something else that could be contributing to their symptoms. The cystoscopic evaluation showed persistent, significant BPH in his prostatic urethra, which I felt was contributing to his symptoms. I chose to go forward with a HoLEP after discussing the procedure with the patient. He had had 2 prior surgeries, but the procedures that he had had were ablation procedures, so he had not really had a full treatment that had been tailored to the size of prostate that he had, which I would consider large. It's well over 100 cc's. These prostates do much better if you can physically remove tissue, such as doing an enucleation. When I talked to the patient about the HoLEP, I told him that it is usually an hour to 2 hour procedure, that he would have a catheter in for a few hours after surgery. If the hematuria was light enough, we'd take his catheter out that day and then have him void a few times and go home. And that was a little bit difficult for the patient to understand because with his prior procedures, he had had a catheter in for overnight or at least a couple of days. So this was radically different for him and required some education on that front. Also with HoLEP, there's a 30% chance of temporary leakage of urine or incontinence because I'm removing so much tissue. So I counsel the patient that can occur, but it's only a 1% chance that it would be permanent. The big benefit with HoLEP is that it's meant to last for life. So unlike other surgical procedures that may need another procedure in a few years, which is what this patient had experienced, the retreatment rate after HoLEP is 1.4% at 18 years. It is important to counsel the patients that with HoLEP you will develop retrograde ejaculation, so he will not see his semen, but he had already experienced this with the prior surgeries and the medication, so it was not an issue for him. This video footage shows the cystoscopic evaluation of this patient. You can see that the lateral lobes of the prostate have actually grown together. We would call this synechia, and it happens when there's inflammation or prior procedure and there's tissue left behind, so the lobes will fuse. Then as I enter into the bladder, you can see all of this inflammation and actually adherent calcifications on basically some dead necrotic tissue in this patient's prostate. It's always surprising that this persists many, many years after ablative procedures, but some of this inflammation never goes away. So I've taken a good look inside of his bladder. I can see that there's obstructed tissue, and now I'm going to start the laser enucleation. I use a 28 French scope, so prior to putting the scope in, I've dilated the urethra to 30 French. And now I have a 500 micron laser fiber that I'm going to use to make incisions in the prostate. Right now I'm looking for the ureteral orifices just to ensure that they're well away from the resection area. And I will use this laser to make a cut down the 6 o'clock position of this prostate to get down to the level of the capsule. Where I make my cut is really just dependent on the anatomy of the prostate. If it's 3 lobes, I'll make 2 cuts. If it's 2 lobes, I'll make 1 cut. In this particular case, the patient has complex anatomy where he's had prior surgery, so I'm just going to make a cut near the 6 o'clock position in a natural groove so that I can take the shortest distance from the urethra down to the capsule. And you can see that there's like a cavity that I enter here. That's from the lobes growing together and the prior treatment, but it is opening up nicely with this holmium laser. My laser settings are 2 joules and 50 hertz for cutting, and I use the Moses technology, which is very good for hemostasis and tissue separation. I'll use 2 joules and 20 hertz for coagulation if I see independent bleeders. And you can see that it's going to take several passes with this laser to cut through all this residual adenoma and get to the capsule. It does separate nicely, which is really nice with this technology. And you can see that there's just quite a bit of residual tissue. The tissue is extending into the bladder, so I have to take care to not injure the ureteral orifices. And so what I'll often do is to turn the outflow from the scope out. The scope has an inflow channel and an outflow channel, and I usually leave the irrigation inflow wide open and the outflow wide open unless I'm working around the bladder neck, and then I turn off the outflow to get the bladder to distend up and away from the prostatic capsule. So I continue to dissect down through the layers of the tissue until I can see these slick area in the back here. This is the capsule. So the laser reacts differently to the capsule than it does to the BPH. It's slicker, it doesn't have that fluffy appearance. So I know that I've cut through all the abnormal tissue to get to that slick capsule. Now I want to connect that cut to the lateral lobes. So I'm going to take the laser and I'm going to cut under this tissue and do what I call the lateral sweep or the lateral cut. And I'm joining that median lobe tissue into the lateral tissue with that cut. And it's just straight across. Then I will use the scope to turn around the apex of this prostate. I will use a laser energy of 2 joules and 20 hertz to encircle the apex of the prostate. I'm working just lateral to the viru. And this little wisp of tissue here, this is what we call the apical strip or the mucosal strip. And we want to divide that early so that it's not tugging and pulling on the sphincter muscle. So you can see that I'm using the laser to cut that strip of urothelium up to a point at 12 o'clock that I've deemed appropriate, which is right above the viru montanum. I'm going to go back to that 2 joules and 20 hertz and continue to release the adenoma from the capsule as I rotate around from 6 o'clock up to 9 o'clock up to 12 o'clock until I get over to around 12 to 1 o'clock, just releasing the right lobe of the prostate. Now I'm going to do the exact same thing on the left-hand side. Again, I'll use the laser to cut through the urothelium, sweep under the lobe to get the plane developed between the capsule and adenoma. And now I've created a pocket that I can just put the scope in and twist the scope around the apex. Now, using a lower energy of 2 joules and 20 hertz, I'm going to dissect the left lobe apex, and I'm working backwards this time from 6 to 3, and then eventually up to 12, so that I've released the apex of the prostate completely. This is technically the most difficult part of the HoLEP, but it's great to start here, especially in patients who have had prior surgery, because this area of the prostate is relatively undisturbed, and it's preserved. And you can see that there's a perfect plane between adenoma and capsule, as you can see here. Now I'm going to meet the other plane that I've created from the other side. I need to cut the urothelial strip on this side as well, just like I did on the other side, to release that mucosa. And now once this is done, the sphincter is really out of the picture. We're not tugging and pulling on the sphincter. There's no risk of damage, and it is preserved. So we do that early. It's called an early release, so that the sphincter has less bruising and damaging during the case. Now I'm about to join the left lobe to the right lobe at the 12 o'clock position. So these two planes now meet perfectly. So we have the apex completely freed at this point, and I can do what we call the anterior plane. The anterior plane is just releasing the adenoma, which is below me, from the capsule, which is above me. This is also somewhat difficult for learners because they don't get deep enough to truly develop the plane on their turns. But if you do a good job with your apical turns, this plane is very easy to identify. You can also see that I use the laser to do a lot of laser dissection, not blunt dissection. And I think this gives us the hemostasis that we need for that same-day discharge. So the adenoma is below me, capsule is above me, and I'm continuing to dissect. I have to point the laser more upwards or towards the 12 o'clock during the initial dissection, because the prostate is a globe, it's a sphere. And so until I get to the equator of the prostate, I'm pointing upwards. Now once we cross the equator, I then start to point downwards. So this requires some subtle movements and adjustments to go from upwards to downwards. But the capsule, I think, is very, very easy to see at this location. And you can see that this prostate is opening up nicely with very little bleeding. Now, as I work towards the bladder neck, I will encounter more blood vessels. And because it's a redo, I'm not going to see the standard landmarks that I would normally see with a virgin prostate. This patient's had prior procedures, so the bladder neck fibers have been removed with the prior surgery. So I will just eventually erupt into the bladder, which can be a little disturbing for new surgeons, but it's nothing to worry about. You will see the bladder and it will release appropriately. Sometimes there can be fairly significant scarring around the bladder neck if patients have had prior surgery as well, which has to be released. Now right here we have a significant bleeding vessel, but you can see that using that 2 joules and 20 hertz coag, it stops bleeding immediately. So with this current laser technology, we're really able to be efficient. The bleeding vessels can be controlled rapidly. It doesn't take a lot of time and energy. And you can see now we are entering into the bladder. There's that area of prior resection from the prior green light. And I'm just opening up the cavity so that the anterior plane now joins through the bladder neck. And I'm taking down the lateral wings of the bladder to make a nice wide open bladder neck for this patient. Now I'll go back through and make sure that I control all bleeding on the capsule as I pull backwards to the apex so that it's nice and dry on this capsule on the top. And now I'm just going to take down the lateral lobe just a little bit more. and make sure that it's freed up completely anteriorly on both sides. So despite having had prior procedures, this patient has excellent surgical planes, very easy to follow, and really this prostate tissue wants to be removed. It has a good plane between capsule and adenoma that's easy to dissect. And so when we get close to the bladder neck where there was the prior surgery, you're going to see more inflammation and more bleeding. So I just take my time and stop and control the bleeding as I go so that I'm not trying to get it all cleaned up at the end of the case. And that blood vessel there is fairly significant. There's usually one at that location in every prostate, just near the 3 and 9 o'clock positions. And you can see here that we continue to take down the bladder neck on the patient's right-hand side just to really open up that bladder neck. And the reason I want to open it up so much is that it makes depositing the adenoma once it's released very easy. I have to move this adenoma into the bladder, and if they make the bladder neck too tight, it'll be very difficult to move that tissue. So I spend a lot of time dropping down the bladder neck laterally. And again, just controlling those blood vessels before I move on. He does have quite a bit of inflammation, so sometimes that can take a little more time to control it. We have one more bigger vessel up here as well. So you can see that because this laser is so hemostatic, it's safe to use in patients who are on blood thinners, patients with bleeding disorders. They will have more hematuria after the case than someone who's not on blood thinners, but they do quite well. Okay, now that the anterior plane's developed, I'm going to divide the prostate lobes into left and right halves. I'm starting at the apex, and I'm working towards the bladder neck. I'm going from the true lumen up to the anterior plane that I have created and just dividing the lobes in half. I do this because, again, I have to deposit this tissue into the bladder, and it's much easier to deposit 2 smaller lobes than 1 large lobe into the bladder. Okay, so now I'm going to start at the right corner. I call it the corner because I'm joining the posterior plane to the anterior plane through the lateral corner plane. And so I just work up from that anterior plane that I've created back down to the posterior plane that I'm developing. And by working the corner, I think this saves so much time. When I see new learners trying to do HoLEP, they want to work posteriorly and laterally and anteriorly, and they never really think about joining the planes together. But these bigger movements, moving from the anterior plane to the posterior plane in one big sweep, keeps you from developing multiple planes that you then have to join together later. So I really urge any of my trainees to just work the corner. It's harder, it's technically more difficult, but if you can master that, you save a lot of time in the long run. And it's the difference between a 2-hour HoLEP and an hour HoLEP by keeping your planes all in order. So I'm back up at the bladder neck again, and I'm just trying to get down that scar tissue. The scar tissue does not cut as easily as regular tissue, so it can be, for lack of a better word, kind of gummy, and it can take a little bit of time to cut through. Now I've gone back posteriorly, and I'm joining my lateral plane to the posterior plane on this right lobe. And as I work towards the bladder neck, I always work forwards. Some people like to try and work backwards, and I think that you can lose your plane that way as well. So I always move back to behind the prostate, near the apex, raise the tissue up with my scope, and then dissect with the laser as I work towards the bladder neck. And you can see that the tissue just naturally wants to sit on top of the scope. So I am using gentle pressure to elevate the tissue up while I use the laser to dissect. And I'm working from that lateral plane to the posterior plane and the lateral plane to the posterior plane, and just constantly keeping all my planes in order as I work. I'm also controlling bleeding as I work so that we don't have a lot of bleeding vessels that are continuing to bleed through the case. I only focus on the bleeding vessels that are on the capsule, not on the adenoma, because the adenoma is coming out. So if there's bleeding that's occurring from the adenoma, that will eventually stop as I detach all the blood vessels. Now, posteriorly, I need to take the dissection to the first cut that I made, so to make sure that we're all joining up into the same plane. And so I continue to work laterally to medially, pulling the planes together until this tissue naturally rolls into the bladder like you see here. Now the tissue has rolled into the bladder, and now I'm just going to detach those final attachments to the capsule and bladder neck using the laser. Now again, I'm going to turn down my outflow because I'm working around the bladder neck. I don't want to damage the bladder, so I turn down my irrigation outflow by keeping the inflow on high. And this way the bladder will move away from the bladder neck so that I don't inadvertently what we call back wall or injure the bladder with the laser. And this really depends on what kind of irrigation tubing that you have, outflow tubing, but play around with the flow so that you understand what it takes to get the bladder to distend. And I'm working all the way over to that first cut I made to just release all of that tissue, including that median lobe tissue that we saw when we first looked in, and to open up this channel. And I'm moving, somewhat slowly just to control the bleeding. And again, it's that kind of gummy scar tissue, so it takes more time to cut. I'll also go in and pull the tissue back to see where the ureteral orifices are to ensure that I do not inadvertently cut across those orifices with the laser. So releasing from the bladder neck can be a little tricky when you first start doing HoLEP. But just take your time and be careful. I see a lot of people leaving big chunks of tissue at the bladder neck because they're worried about taking the tissue too close to the bladder neck. Those residual pieces can bleed and grow, so it's important to hug the bladder neck and stay close and not leave residual tissue in this area. So I'm really incorporating the median lobe now into the lateral lobe to just make this nice, smooth, clean surface at this patient's bladder neck, which is what he really needed. If you think back to when we did the first cystoscopy, there was all that inflammation, calcification. There's the ureteral orifice there. And now it's just going to be a smooth, plain, without any area for inflammation to occur. And I'm taking my time here so that I can ensure that we have a nice smooth plane, that I'm not going to injure the back wall. And now I'm just releasing that medial portion of the median lobe from that first cut that I made. And it's just very satisfying to see how this cleans up so nicely for this patient. You can see all that inflamed tissue just rolling into the bladder and away from his prostatic fossa as we release that last little urothelial attachment right here. And this is extremely clean. All right, so the right lobe and median lobe are out. Now we just have to do the left lobe and we're done. The second lobe goes much, much faster than the first. I've created space in the prostatic fossa so the tissue can easily roll. And again, same principles as the right side. So I work the corner. I'm working that anterior plane all the way up to the bladder neck to create this lateral plane that will join the posterior plane. I want to make sure that I really take down this bladder neck. I did quite a bit of that with the anterior plane, but I'll take it down more with the lateral plane. And I'm entering into that area of scar tissue. It was a little more prominent on this side than it was on the other. And then I just work lateral to medial to continue to develop that plane. Although the movements are fast, I'm always working forward. It may look, when you look at the video, like I'm moving forward and backwards, but I'm actually only working forward. I just make micro adjustments with the scope to keep the laser movement in a forward progression. and we are hitting more of that calcified scar tissue at the bladder neck. Now we're back at the apex, and we're just going to take the lateral plane and join it medially. Very little left attaching this lobe to the capsule. So usually when I'm training, I will do the first lobe myself and get that out of the way, and then guide the resident or fellow through the lateral lobe because it is just a much faster and easier way to learn. Again, more blood vessels that we're just controlling. And I'm working that plane medially. The tissue will naturally roll up over the scope, just like the other side. And it's really surprising, given that he's had 2 prior procedures, how much tissue he has left. But it's just a testament to how the prostate will grow if the tissue's left in place. The prostate's an interesting organ. It's the only organ, one of the only organs that grows throughout the course of your lifetime. Just like your nose and your ears, it just gets bigger and bigger. So for some men, it grows exponentially faster. One epidemiologic study that was performed in Olmsted County, Minnesota, studied men over 20 years and found that the average growth rate for the prostate is 2.2% per year. But clearly some men grow exponentially faster than that, and some men have very little growth. So without any type of intervention, the prostate symptoms generally get worse. Some men can be handled with medication alone, but if your prostate is this big, it's very difficult to manage your symptoms with lesser invasive measures such as medication. But there are some men who have extremely large prostates with minimal symptoms. And you can have a small prostate with very significant symptoms. So it's just important to really treat the patient and not use a cookbook approach to everyone. So we're getting to the end of this particular lobe. Again, just rolling the tissue up to the bladder and taking down those lateral attachments. And I think this patient is going to feel much better once this is released. And you can see there's some nodular growth on this side that's kind of protruding out into the capsule. So I will come back and try to reincorporate those into the adenoma as I'm working. I don't leave the nodules behind and try to take them out later. That's very difficult to do. You want to try to keep them attached to the main prostatic mass if you can. If you try to just get the nodules out later on their own, they're very small and they're hard to manipulate with the scope. So a bigger mass is easier. Now I'm pushing the tissue into the bladder, and now that left lobe has rolled into the bladder, and I am detaching those attachments to the bladder neck right here. Now this is much faster because it's a much smaller attachment, but it's the same principle. I'm turning down my outflow so that the bladder does not get injured as I release. And the enucleation is now complete. You can see that the ureteral orifices are well away. Now I'm going to go through and I'm going to do some aggressive coagulation. I use that 2 joules and 20 hertz to basically coagulate anything that's red and could potentially bleed and cause issues. But you can see there's not that much bleeding left once the tissue is out. There's a little bit always around the viru because we've done very little laser dissection here. But there's not much bleeding to control once you get the adenoma removed. Just a small vessel there to control. Now we have to get the tissue out of the bladder, and I will use a device called a morcellator for that. But before I do that, I want to ensure that there's nothing that's actively bleeding that will obscure my visualization. With the morcellator, you do not have continuous flow. So now I've put the morcellator into the bladder. It's all inflow, so there's 2 water lines that are flowing in, and the only outflow is the morcellator. The morcellator has these oscillating blades that you can see in the image, and I've got the bladder very distended, and I'm suctioning the tissue that I enucleated down into the morcellator, and then using the morcelator to chew up the tissue and remove it. So when it comes out, it looks somewhat like a paste that is all collected and sent to the pathologist so that they can look for any potential prostate cancer or any abnormalities. The morcelator can remove some calcifications, but not much. Usually you want to get those out of the way before you morcelate because they will jam the morcelator. I also like to pull the tissue close back down into the fossa that I created. That's a safer place to morcelate. So I start in the bladder, and as the tissue pieces get smaller, I pull it back into the fossa so it becomes more efficient that way. Once morcellation is done, I'll do another drying up cycle with the laser again. And this is really important if you're planning to take the catheter out the same day. You need a really dry prostatic fossa if you're going to take the catheter out the same day. So I will just go around and get any significant vessels that appear to be bleeding and control those before I put the catheter in. But you can see this is extremely dry. I have very little flow on at this point. There's minimal bleeding, but I will just ensure at the bladder neck that there's no further bleeding. And this looks great. That's with the flow off. So this is extremely dry prostate. You can see that I actually removed the urethra where the prostate is. I often get asked by patients what happens to the urethra, and I'm actually removing it with the prostate. The urethra is just a skin layer, so it will grow back over that surface that I create. So if we looked back into this man's urethra in 3 to 6 months, it would look like a new urethra had grown over the surface of the prostatic capsule. So it just grows back in over time. The image is of this individual's catheter. You can see that the urine is very clear, it's pink tinged. Some people will have more bleeding if they're on blood thinners or have a bleeding disorder, but for a standard patient undergoing HoLEP, this is often the color of the urine that we see. His catheter was removed 2 hours after the procedure. He urinated twice in the hospital, so we would have him urinate and then check an ultrasound residual to make sure that he's emptying his bladder. And after he had done that successfully twice, we sent him home. I called him a week later with his pathology report, which did not show any cancer. And he said that he was very pleased with his results, that he had not urinated like that in many, many years, that he had had some leakage of urine for about 2 to 3 days that resolved. He had burning with urination for the same amount of time, for about 2 to 3 days, which had resolved. And the blood in his urine he had not seen for 2 days, so he had it for about 5 days. I asked that he not do anything strenuous for 1 week after surgery. That second week, he could resume some cardio activity. And then 2 weeks after surgery, he can start lifting and doing more strenuous activities. I told him no biking for a month. And then I would do his first follow-up at 3 months to ensure that he's doing well. If everything looks great at 3 months, we check a PSA, we check a flow and a post-void residual, and we check his symptom scores. His PSA should be around 1 or less. If it's 1 or less and he's pleased, then I just tell him that he needs yearly cancer surveillance till the age of 80.